Teresa's going to switch the slides around again. So I want to introduce our next speaker, Nicholas Ah Mew with Children's National Hospital in Washington, D.C. Dr. Ah Mew is the director of the Inherited Metabolic Program at Children's National Hospital. He was also the principal investigator on the recent study comparing treatment options for urea cycle disorders. Some of the resources from that study are already on the NUCDF website. We're going to be adding more with his help soon. And his talk today is going to focus on making the choice between medical management and liver transplant, the family experience.
There we go. I don't want it to go dead on you. Okay, and there's your clicker.
Thank you so much. It's a pleasure to be able to present some of our work here. I want to highlight that all of the work here actually formed the basis of a PhD thesis by Dr. Maya Gerstein. So, as I said, all of the work here is hers. I also, I notice here today that as we learned a bit earlier, that there's many families that have been at this conference before and likely participated in this project, so thank you for having done so. And then many new families as well who are here, so I hope this is helpful to you, and I hope you'll see some of the many themes that we talk about that potentially resonate with you. Dr. Mazariegos kindly introduced some of the work that we'd done. And just very briefly, as many of you know, in terms of treatment options for UCD, you can kind of lump them into these two major categories: medical management that involves medications as well as dietary treatments, or liver transplant that removes the risk of hyperammonemia but might have the additional risk of surgical complications. And so many families, and I understand in discussion with Teresa that this is in fact the number one question that comes up to her often from new families calling, is whether or not a particular patient should be treated with diet and medications or should a liver transplant be considered. More recently, so at the time we did this research, this wasn't available, but more recently, of course, there have been several clinical trials that are now offering gene therapy. So that's one additional option here that obviously we were not able to study at the time, but I understand we'll have a talk by Dr. Sean McCandless later today on this topic. So about the study, again, at the time there was no existing research on treatment decision-making in UCDs. And this study was conducted in collaboration with the NUCDF, so Cindy Lamont and Teresa Warner and Janice Bartos, as well as the patient-powered research team, the GW School of Public Health, again, Dr. Maya Gerstein and Marcos, and us at Children's National. And so we wanted to examine how UCD treatment decisions are made and to describe the factors that influence a family's decision to either continue medical management or choose liver transplant. And so the idea, we wanted to better understand this process so that providers who are helping patients who have urea cycle disorders can help potentially help them make those decisions, but also provide information in a timely fashion to those families. So we conducted a series of phone interviews with parents of children diagnosed with urea cycle disorders, so a total of 34 families. They had a variety of forms of the urea cycle disorders. So some had neonatal, some had late onset diseases, some were medically managed, and some had been transplanted. And so we tried to get children of all ages and living in different states or regions of the country. We also did phone interviews with a total of 26 clinical providers, again, metabolic physicians, transplant physicians, dietitians, nurse practitioners, and they were also located in different parts of the country. At the NUCDF meeting, if I'm not mistaken, in 2018, we held some in-person focus groups, as well as web-based focus groups. There was a total of 31 parents. And we also similarly held focus groups with providers, a total of 19 of them. And so with all of this data, with all of this information, this was then coded to identify themes that they were in common that came out in each of these focus groups and interviews. And with that, we found that these specific themes ended up being clumped into specific categories. And so as Dr. Mazariegos shared a little bit earlier, this is a conceptual framework that we had designed here to kind of explain all of this in this process. This is a lot right now. I want to highlight really at the center of all of this is weighing the risks and benefits of these treatment alternatives as it relates to liver transplant or medical management. But I want to go through each one of these different inputs individually. So again, parents, as you know, put considerable effort into understanding and analyzing the risks and benefits of medical management or liver transplant. But unfortunately, there's been limited scientific evidence to inform this decision, and so it's been that parents and providers often struggle with comparing these two options. And so the parents ultimately rely on experiences, their own, their providers, and their peers and their social group to guide this choice. And so we identified that there are clinical, personal, social, and system-level issues that informs each family's personal perception about the risks and benefits of transplant. So once again here, just highlighting that these are the clinical, personal, social, and system factors that input into this decision-making process. As Dr. Mazariegos also highlighted, that major changes during key phases of a child's development create new or aggravate existing challenges related to medical management of UCDs. And so these developmental phases, or the transition from one phase to the next, can be a catalyst for parents to reconsider liver transplant as an option. And so this may change patient and parent priorities and reframe the family's perception of risks and benefits of medical management versus liver transplant. So throughout this talk here, I've also pulled out some quotes from families, and I'm just going to read them out to you because I think they're really instructive and share what families are thinking about. Although I grant I'm not a great dramatic reader. But so this is what one family shared. It's just a new chapter in our lives. In order for the possibility of our daughter, being able to maybe go to college, just be able to think about things like that. If we can't get it under control now, I don't know how we're going to be able to get it under control in the next couple of years. So again, once again, I've listed these four major groups here, four major categories: clinical, personal, social, and system, and I want to start at the very top. So there are two components to this. First, I want to talk about the disease severity. The severity of diagnosis was cited by patients and providers as a really key consideration of a treatment choice. And so obviously if you have a neonatal onset UCD and you have no enzyme activity at all, then liver transplant was commonly described as the child's only option or the best chance at long-term survival. On the other hand, if you have late onset disease or partial enzyme function, then this was a much more subjective and complex evaluation. But also, as many of you know, disease stability is not the same throughout one's life, and so their periods of instability were also catalysts for transplant. So transplant was seen as a preventative measure to potentially avoid instability and preserve neurocognitive function. So for some, even though their child may have been stable throughout their life so far, that past or current disease stability was not an indication of future disease control, and so some families opted for liver transplant because they feared this unpredictable nature, as you all know, of high ammonia levels. These two quotes are taken from families that have made two very different choices here. The first, from everything that I've heard, it should be for us more of a last resort scenario. My daughter's condition, for the most part, has been pretty well controlled. In my mind, if that's still feasible for us, then why would we take on the risks that are associated with liver transplant? And another family shared tons of reasons as to why we felt transplant was a better option, even though he was quite a stable kid, but everyone told me that That might not be the case forever. That can change literally overnight, so that's why we decided to go for the transplant. So beyond the disease itself, there's burdens on the family as well as burdens on a child that are important factors in the decision-making process. As many of you know, the difficult day-to-day challenges of managing UCD, this is really a 24/7 job. There are things that can happen essentially at any time, and so that fear and worry and anxiety that families have can have a tremendous impact. And of course, it can alter the relationship to the typical normal life comforts, if you will. And so these daily burdens can be a compelling reason to consider transplant. But on the other hand, these burdens may not drive families to pursue transplant when they already feel they understand the condition really well and they have a really good control of everything, and that the concerns about the new risks associated with transplant they feel are much greater than those than dealing with a UCD on a day-to-day basis. There are also burdens on a child to consider here, in particularly with regard to a child's quality of life or the intellectual and social development. And so many parents asked, can transplant offer a child an opportunity to normal or better quality of life? And parents who felt that a child was thriving socially and intellectually were much less motivated to pursue transplant. Here's a quote from one family. That was one of the things in school. He learned to count money, and that was a huge thing because he worked and worked at it. Then he had a high ammonia level, and he remembered that he knew how to count money, but that he couldn't count it anymore. We thought, oh, that quality of life is horrible. To lose that functionality was devastating for him. That played into the decision to transplant too. So of course, again, we talked about the disease, a patient and the family, and of course that's also in the context of a social environment and the people we interact with. We're all obviously here at the NUCDF conference. There are many folks that are very active on social media, and these different inputs play a really important role in this decision-making process as well. And so, again, it's not surprising, but obviously that those who might be more motivated to transplant have reached out or spoken with families that have had positive experiences with liver transplant and have had negative stories, or they've heard about negative stories from families that have delayed the transplant or had not obtained a transplant. On the other hand, there are some who are discouraged to get a liver transplant because they've spoken with those who have had surgical complications from the transplant, or they've had relatively good success with medical management. This from one family. I probably wrote back and forth with about 6 or 7 or 8 different moms for a couple of months, just hearing their experiences, asking if they feel that dealing with transplant life is easier than a UCD. A lot of their opinions really helped make my decision. Families also, in a social context, also consider, what their future life for their child will be like, and their considerations for a child's independence play also a really important role. So for instance, being able to participate in preschool or grade school programs, or living outside the home and attending college, and later on learning to live independently with a UCD, teaching a child to manage their own UCD needs, and living safely and independently outside the home, this certainly plays an important role too. And being able to, whether a child's able to handle that or the families feel like that was going to be really difficult, is an important factor. For her independence, a transplant is necessary. When her ammonia level starts to rise, she can't make decisions on how to help herself. Living on her own and going away to college was not going to be an option. So lastly here, there's some system level things, and really what we meant here was more medical system level factors that also play a role in whether or not families chose to proceed with transplant. The first is with relation to access to quality metabolic care. So concerns about the local metabolic team and emergency medical management options was a consideration for transplant for many families. Parents who had really high confidence in the metabolics team to manage a child's urea cycle disorder were often less motivated to explore transplant. And so we have quotes here from two different families that had two very different experiences. All of these little things were adding up for us. Okay, he didn't have a crisis for 8 months, but they're not able to quickly handle it. If we weren't watching like hawks all the time, would he survive? When we were in there, my faith was that these people were going to save his life, and suddenly I couldn't count on them to do it right. But there's another family that shared, I'm confident that if she does get sick, we're in the right place. I trust the team here very much. The reason liver transplant is not forefront in my mind is because we are with this department and we're with this doctor. The input of the treating physicians are also really important in the family decision-making process. This can vary from institution to institution and from physician to physician. And there's some groups that are very, very pro-transplant and will recommend that option very frequently. And there are many institutions where the physicians feel like that is only for severe cases and will only recommend those as the last option. And there's some centers as well who will defer this choice entirely to the family. And so this input can definitely have an influence on a family's approach. Lastly, cost and coverage of treatment can play a tremendous role, and there are tremendous differences in the cost and coverage of medical management versus liver transplant. In terms of medical management, and I think many of you may already be familiar with this, is the disputes with insurance companies and limited coverage for medical formulas and medical foods. With regard to liver transplant, and granted, this is only for those in whom it's gotten covered, and sometimes that's a challenge for those uninsured or those whose insurance will not cover a liver transplant. But once coverage is, once a liver transplant is obtained, then it's following the transplant, it's oftentimes much easier to continue getting medical coverage for everything related to the liver transplant with little out-of-pocket costs. And so that financial burden of UCDs contributes to the overall burden of the disease on the family. This quote, I think many of you will be familiar with this type of experience, and kind of makes me upset every time I read it. It's too hard. The struggle between insurance and where you work and getting covered. It's a full-time job just to get medication. The nutrition many times is not considered medically necessary, but is medically necessary. Then you're constantly battling with your insurance company. It's hard enough emotionally to deal with a condition, but then to have to be bullied by insurance companies, the amount of money that we spent the first 5 years that she was diagnosed, we were living in poverty, but our income was well above poverty. We couldn't comprehend how it could cost this much out of pocket to be able to keep her alive. So again, all of these are factors that families consider in terms of this decision-making process. Again, part of the reason we did this research was to be able to better understand this and to codify this, and so that, as I said, many of these quotes may resonate with many of you. Oftentimes for families, as a result, it leads to a tipping point, some event that happens that families feel like, this is it, we're not going to deal with this anymore, and that often tends to be the driver at that time to proceed with liver transplant. So what does this mean? Again, the reason we did this framework equips us as providers with this evidence-based account of the patient experience that hopefully means that many of us will adapt our approach to treatment counseling and better be able to anticipate the needs of patients and families and prepare for more productive patient interactions. But also this framework could be considered in future guideline development and allow us to promote more patient-centric approaches to counseling that accounts for this evidence of the patient and family experience. I could only today describe a part of the research that we did. Dr. Mazariegos was kind enough to highlight our article here. I'm putting it up again. You'll see the link at the bottom. If you go to that directly, there'll be another link there that will direct you to a copy that you can freely download. It has some of this research in a little bit more detail, as well as many quotes from additional families. that are there, once again, that many of you may find helpful or resonate with you. But the other thing we also want to highlight is that in order to help families better understand some of the work that we're doing with regards to medical management and liver transplant, we had converted some of our research, this part as well as some other research that we'd done with regard to outcomes, into what I think are easily viewable videos that currently right now are accessible through an app that was part of this project that was funded by PCORI. We're in the process of working with Teresa and Jill to find a way to have these incorporated on the NUCDF website as part of an educational portal. But for the moment, these are still available here. Again, it was part of a research project that's now closed, but there's still a mechanism to access those videos here. So with that, I want to thank everybody again, Maya Gerstein and Ann Marcus at GW, the NUCDF, Cindy, Teresa, Jan Bartos, and the patient-powered research team, as well as our funding agencies, PCORI, and also all the families and who contributed their time and shared their stories with us. We really appreciate this, and all of that helped go into this research. I do want to end, because I know the theme today is for this entire conference is about Cindy. We had these two projects that were funded through PCORI that Cindy was instrumental in and really formed, she was a force of nature, and these projects would not have been possible without her. And I shared with you a little bit about these videos that we had made that unfortunately in the middle of that project, Cindy had passed away. As many of you know, Cindy had already devised a plan, and the appropriate folks at NUCDF who could pick up from the work that she had done with us, and we were fortunate enough to continue work with Teresa and to see this project through. About my last communication with Cindy was by email, and this was about a week before she had passed. I realized all the things she probably was going through at the time and how difficult that was, but I want to highlight that last email to me was full of hope. Again, part of our theme today, but hope for the UCD community and hope to find a cure for all the Urea Cycle disorders. So actually, I have that email printed out. It sits on my desk and has remained there since her passing, and it serves as a motivation for me to continue doing what I do. So again, I just wanted to acknowledge Cindy's contribution to all the work that we've done here, and I want to thank you for your time.